imagine a mystery illness in a little kid. They get this stubborn fever, maybe a rash, and it turns out it could have serious consequences for their heart down the line.
Yeah. It sounds pretty intense, right?
It does. Well, that's the puzzle we're tackling today on the deep dive, Kawasaki disease. So if you're prepping for your MSRA, you'll really want to pay close attention because we've distilled everything you need to know about this condition into, well, a super focused session.
Exactly. Think of this as your rapid-fire review of Kawasaki disease. We're going to cover all the crucial angles for your revision. You know, what it is, what might cause it, who's at risk,
Right.
what's happening in the body, what else it could be, how common it is, how it shows up, investigations, management,
Works.
prognosis, complications, yeah, the whole lot. Our mission is basically to make this information stick for you.
Okay, brilliant. Let's get straight to it then. What is Kawasaki disease in a nutshell?
Okay, simply put, it's an acute systemic vasculitis.
Vasculitis. Inflammation of blood vessels.
Exactly. Sudden inflammation throughout the body. You might also hear it called Kawasaki's disease, Kawasaki syndrome, or mucocutaneous lymph node syndrome. They're all the same thing.
Gotcha.
The key thing is that it primarily affects young children. And the biggest worry, the thing we really focus on, is its potential to cause serious heart problems.
Like coronary artery aneurysm.
Precisely, coronary artery aneurysms. We think it's triggered by an abnormal immune response, probably after some kind of infection, in kids who are genetically more likely to get it.
Right, so the body's own immune system sort of overreacting.
That's the leading theory, yeah.
Interesting. Let's delve into the why a bit more. The etiology. What do we actually know about what sets this off?
Well, the honest answer is we don't have a definitive cause pinned down, not yet.
Okay.
However, the strongest evidence suggests it's a combination of things. Probably an infectious trigger, maybe a virus or bacterium. We haven't quite identified yet acting on a child with a certain genetic susceptibility.
And we definitely see this more in certain ethnic groups, don't we?
Absolutely. There's a significantly higher incidence in Asian children, particularly those of Japanese and Korean descent.
That really points towards the genetics, doesn't it?
It really does. This strong ethnic link is a big clue. And family studies have shown, you know, if one child in a family gets Kawasaki disease, their siblings have a higher risk. Plus, genetic research has started identifying various genes and sort of immune pathways that seem to be involved.
So it's like a perfect storm. An infection hits someone with the right genetic makeup.
That's a pretty good way to think about it, yeah. This interaction likely sparks that widespread autoimmune-driven inflammation in the small and medium-sized arteries, and that affects various organs during that initial acute phase.
Okay, so who are the individuals we should be particularly watching out for, the risk factors?
The main ones we know are age, ethnicity, and that likely genetic predisposition.
Age first.
Age-wise, the vast majority of cases really are in children under 5 years old.
Under 5, okay.
And as we said, ethnicity children of Asian descent have a much higher risk.
Right.
And while we don't have a simple genetic test for it, a family history of Kawasaki disease should definitely raise your suspicion.
Right, that paints a clearer picture. Now, biologically, what's actually happening? The pathophysiology.
So the core issue is inflammation, specifically targeting the small and medium-sized blood vessels.
And critically, the coronary arteries.
Critically, yes.
Yeah.
The ones supplying the heart muscle. This inflammatory process leads to the release of a whole cascade of inflammatory mediators, things like cytokines.
Right.
And these chemicals basically damage the walls of these blood vessels.
And it's this damage that's the real danger here.
Precisely. Because that weakening of the vessel walls can then lead to the formation of those coronary artery aneurysms, which, as we've said, is the major concern with Kawasaki disease.
Makes sense. Now, thinking practically, a young child with a fever, that's incredibly common.
Oh, absolutely.
So what else could it be? What are we differentiating it from?
That's a crucial point for your MSRA. You have to be able to tell Kawasaki disease apart from other childhood illnesses that present with fever.
Okay.
We need to consider, well, lots of things. Viral infections, bacterial infections, other conditions involving inflammation, or things that just mimic the symptoms.
Can you give us some of the key players in that differential diagnosis?
Sure. Think about common viral infections first, like measles, rubella, infectious mononucleosis, maybe enteroviruses, parvovirus B19.
Okay, the usual suspects.
Yeah. Then on the bacterial side, you've got staphylococcal and streptococcal infections. They can sometimes look similar, especially things like scarlet fever or staph scalded skin syndrome.
Right.
Then there are other inflammatory conditions, toxic epidermal necrolysis, drug reactions like erythema multiforme, or Stevens-Johnson syndrome.
Okay.
And don't forget things like meningitis and syphilitis, tick-borne illnesses like Rocky Mountain spotted fever, even rarer things like mercury poisoning, which used to be called acrodynia, or toxoplasmosis.
Wow, that is quite a list. Any tips for remembering all those under pressure?
Definitely. Grouping them helps. So think viral, bacterial, other inflammatory drug reactions.
Good idea.
And try to link them to specific differentiating features. For example, Koplik spots shout measles, right? Or the specific rash distribution in Rocky Mountain spotted fever. Those clues can help you narrow it down.
That's really helpful. Okay, let's talk numbers. How common is Kawasaki disease? The epidemiology.
Okay. In the UK, we see about 8 to 9 cases per 100,000 children under 5 each year.
8 to 9 per 100,000.
Yeah. And interestingly, as we mentioned, it's more common in UK children of Asian descent. Globally, Japan has the highest rates by far, over 2,000 cases per 100,000 under 5s.
Wow, that's a huge difference.
It is, and those numbers seem to be rising annually there. In Europe, the incidence is generally lower, maybe 5 to 15 per 100,000, with Ireland sort of at the higher end of that range.
That ethnic variation is really striking.
It really is, and it persists even after families migrate, which again reinforces that genetic component idea. Sadly, there can sometimes be delays in diagnosis. One UK study found about 7% of cases had a diagnostic delay of more than 10 days reported by GPs.
Which just highlights why we need to be so aware of the signs, doesn't it?
Exactly. Age-wise, about 85% of cases are in kids under 5, with the peak age hitting around 18 to 24 months.
Toddlers, mainly.
Yep. And it's slightly more common in boys than girls.
Okay, so we know who's most at risk. What are the key clinical features that should really make us think Kawasaki disease?
Right. This is prime MSRA territory. A good mnemonic is your best friend here. Think FRASHBI.
FHBI. Okay, I like it. Break that down for us.
Let's do it. F is for fever, persistent high fever lasting 5 days or more. That's the cornerstone.
5 days. Got it.
R is for rash, typically a generalized red rash, but it doesn't usually blister. Can look like lots of things. Polymorphic, they call it.
Okay.
A is for adenopathy. Usually means swollen lymph nodes in the neck, typically just one large one, often unilateral.
Right. Cervical adenopathy.
Yep. S is for strawberry tongue. The tongue looks bright red and bumpy, just like a strawberry. And other mouth changes too, like red, cracked lips.
Okay. Strawberry tongue.
H is for hands and feet. You look for redness, swelling, and then later on, peeling of the skin, especially around the nails, periungual desquamation.
Hands and feet changes.
B is for bilateral conjunctivitis. Redness in both eyes, but crucially, it's non-exudative, meaning no pus or significant discharge.
Just red eyes.
Exactly. And finally, I is for irritability. These kids are often incredibly fussy, inconsolable, just miserable, more than you'd expect even for a feverish child.
FRASHBI. Fever, rash, adenopathy, strawberry tongue, hands, feet, bilateral conjunctivitis, irritability. That's a great mnemonic.
It covers the classics. Remember, ash, by.
So beyond FRASHBI, what other signs or symptoms might we encounter?
Well, you'll see those red eyes we mentioned, the conjunctival injection, those mucous membrane changes, red, cracked lips, that strawberry tongue. The rash can vary a lot in appearance, the swollen lymph node in the neck, and those hand and foot changes can be quite marked, red, swollen, tender to touch. In more severe cases, you might pick up cardiovascular signs, like a fast heart rate, maybe a gallop rhythm or a murmur.
Okay.
Some children might also present with a stiff neck, suggesting aseptic meningitis, so inflammation but not infection. And less commonly, you might find an enlarged liver or jaundice.
And does this illness follow a pattern? Are there distinct phases?
Yes, we generally describe 3 phases. First is the acute phase. This lasts about 1 to 2 weeks.
Okay.
This is when the child is really unwell, high fever, very irritable, often looks quite toxic. You see those rapid changes in the mouth, the redness and swelling of the hands and feet, and the rash often appears, sometimes starting in the perineal area.
And after that initial acute hit?
Then comes the subacute phase. This typically runs from week 2 to about week 8.
Right.
The fever usually settles down during this phase, and the child might seem a bit better overall. But crucially, this is when you see the characteristic peeling of the skin, the desquamation. Often starts around the bottom, then the palms and soles.
Okay, the peeling phase.
Exactly. Some children develop joint pain or arthritis. Their platelet count in the blood can shoot up quite dramatically, thrombocytosis. And this is the highest risk period for developing those coronary artery aneurysms.
So even when the fever's gone, the danger isn't over?
Not at all. Sadly, myocardial infarction, though rare, can occur during this phase if aneurysms develop and clot.
Right, and the final phase.
That's the convalescent phase. This can last for months, sometimes even years. Any remaining symptoms gradually resolve, and the lab tests usually return to normal.
And the aneurysms.
If aneurysms formed, they might shrink or even disappear completely over time, especially smaller ones. But larger ones might persist, and the risk of cardiac issues can remain long-term.
Are there other sort of less common features we might see?
Yes, there are some subsidiary features. Things like inflammation of the heart itself, pancreatitis, or leaky heart valves. Gastrointestinal issues like gallbladder hydrops, where the gallbladder gets swollen, or jaundice, diarrhea. Myelonemia is common. Kidney issues like sterile pyuria, those white cells in the urine without infection. The aseptic meningitis we mentioned, arthritis or arthralgia. Even things like anterior uveitis inflammation in the front of the eye, or sometimes inflammation popping up at the site of an old BCG vaccination scar.
So it really is a systemic illness
Yeah.
affecting lots of different parts of the body.
It absolutely is, which is why putting all those clinical puzzle pieces together is key.
And making that clinical diagnosis quickly.
Exactly. Early recognition is everything.
Okay, makes perfect sense. So if we suspect Kawasaki, based on those clinical features, FRHHB plus maybe some others, what investigations do we actually order?
Well, remember, it's primarily a clinical diagnosis. The tests are more supportive.
Fair.
A urine sample urinalysis might show sterile pyuria, sometimes a bit of protein.
Right, white cells but no bugs.
Exactly. A full blood count often shows a high white cell count, especially neutrophils, in the acute phase. And then later, in weeks 2 to 3, that characteristic rise in platelets thrombocytosis.
And the inflammation markers.
Yep, ESR and CRP. They'll almost always be significantly elevated. They reflect that systemic inflammation.
What about LFTs?
Liver function tests can be off. You might see raised transaminases, maybe raised bilirubin in some kids. An abdominal ultrasound isn't routine, but it might show gallbladder swelling or hydrops if you did one.
ECG.
An ECG might show some conduction abnormalities or signs of strain, but it's not diagnostic on its own.
So the really crucial investigation for the heart is?
Echocardiography. That's the big one. It's absolutely essential.
Why is it so important?
Because it lets us look directly at the coronary arteries. We can measure their size, look for any dilation, or, crucially, detect those aneurysms. It's non-negotiable, really.
Okay, and what about those trickier cases? The ones that don't quite tick all the FRA-HBI boxes, the incomplete Kawasaki disease?
Yes, that's a really important scenario, especially for exams. You might have a child with that persistent fever 5 days or more, but maybe only 2 or 3 of the other main criteria.
Or an infant.
Or an infant, especially under 6 months, with an unexplained fever for 7 days or more. In these cases, you need a very high index of suspicion.
So what do you do?
You'd check their inflammatory markers, CRP and ESR. If they're low, well, maybe it's less likely. You might just reevaluate, perhaps consider an echo if other things are worrying.
But if the CRP and ESR are high?
If they're high, then you need to look much more closely. You'd look for supportive lab findings like low albumin or anemia, or importantly, look for evidence on the echocardiogram, any coronary artery changes.
Oh.
If the echo is positive, or if they meet certain supplementary lab criteria alongside the high CRP-SR, then you generally treat them for Kawasaki disease.
Even without the full classic picture?
Exactly, because the risk of coronary aneurysms is still there. If neither of those situations quite fits high markers, but no echo changes or other criteria, yet you still need to watch them very closely, possibly repeat the echo.
So even in those incomplete or atypical cases, the echo remains vital.
Absolutely vital. It's our best tool for assessing that potentially serious cardiac risk.
Okay, so let's say we've made the diagnosis classic or incomplete. How do we manage Kawasaki disease?
Right, management. Prompt treatment is absolutely key to minimizing that risk of coronary artery problems.
And the mainstays of treatment are?
The 2 big ones initially are high-dose aspirin and intravenous immunoglobulin, or IVAG.
Okay, aspirin in children. That always raises an eyebrow because of Ray's syndrome, doesn't it?
It does, and that's a really important point. Generally, you're right, we avoid aspirin in children with viral illnesses because of that risk.
But not here.
But Kawasaki disease is the exception. The benefits of high-dose aspirin initially for reducing the inflammation and the fever, and then lower doses later for its antiplatelet effect to prevent clots and potentially damaged arteries. Well, those benefits are considered to outweigh the very small risk of Ray's syndrome in this specific context.
Okay, so it's a calculated risk. And the IV, how does that help?
IVE is really the cornerstone of treatment. It's basically concentrated antibodies from donated blood. We think it works by modulating the overactive immune system.
And it prevents the aneurysms.
It significantly reduces the risk. Without IVIG, the rate of coronary artery aneurysms can be up to, say, 25%. With timely IVIG treatment, that drops dramatically down to around 4 or 5%.
That's a huge difference. What's the dose?
The standard dose is 2 grams per kilogram, given as a single infusion, usually over about 10-12 hours, alongside that high-dose aspirin.
And we talked about echo for diagnosis. It's used in management, too.
Definitely. An initial echo is done at diagnosis to get a baseline and check for any existing abnormalities. Then, follow-up echoes are essential, usually one around 1-2 weeks, and then again at 6 to 8 weeks after the illness started, at minimum.
Why the follow-up?
To monitor for the development of any coronary artery changes or aneurysms that might not have been apparent right at the beginning, and to track their evolution if they do develop.
What happens if a child doesn't respond to that first dose of IVIG, if the fever persists?
That happens in about 10-15% of cases. We call it refractory Kawasaki disease. If the fever continues or comes back after the first IV egg dose, we need to consider additional therapies.
Like what?
Often a second dose of IV egg is the first step. If that doesn't work, or sometimes alongside it, corticosteroids like prednisolone are often used.
Steroids.
There's good evidence they can help reduce inflammation in refractory cases. Beyond that, for really resistant cases, we might move to biologic agents that target specific inflammatory pathways, like anti-TNF alpha therapies. Infliximab is sometimes used.
Right.
Other immunosuppressants, like cyclosporin or cyclophosphamide, have been tried in very difficult situations, maybe even plasma exchange in extreme cases, but these are less common.
And if those coronary artery aneurysms do develop, despite treatment, how are they managed long-term?
That depends very much on the size and severity of the aneurysms. It requires long-term follow-up with a pediatric cardiologist.
Okay.
Regular echocardiograms are needed to monitor the size and function. Cardiac function tests, too. Depending on the aneurysm size and whether there's any risk of blockage, long-term antiplatelet therapy, usually low-dose aspirin, is standard.
And for larger aneurysms?
For larger or giant aneurysms, anticoagulation with warfarin or low molecular weight heparin might be needed in addition to aspirin to prevent clots forming inside them.
Are interventions ever needed?
Sometimes. If an aneurysm leads to significant narrowing or blockage of the coronary artery, procedures might be necessary. Things like thrombolysis to dissolve a clot, balloon angioplasty to open the vessel, maybe putting in a stent. In severe cases, yes, coronary artery bypass surgery might be required, even in children, though that's relatively rare.
Wow. It really underscores the need for specialist input.
Absolutely. Pediatric cardiologist involvement is essential if any coronary artery dilation or aneurysm is detected, and certainly if any intervention is being considered. The whole management strategy revolves around squashing that inflammation quickly, preventing those heart complications, dealing with refractory cases, and then careful long-term monitoring.
Okay. So thinking about the long term, what's the prognosis generally like for kids who've had Kawasaki disease?
Well, the prognosis really hinges on that cardiac involvement. The good news is, with prompt diagnosis and treatment with IVIG, the vast majority, probably over 95%, make a full recovery without any significant long-term problems.
That's reassuring.
It is. But as we've hammered home, untreated cases have that 15-25% risk of coronary artery aneurysms. Early treatment drastically lowers that risk.
And if aneurysms do form, do they stick around?
Often they regress. About half to 2/3 of smaller aneurysms will resolve, usually within 1 to 2 years.
But not always.
No. Larger or giant aneurysms are much less likely to resolve completely, and they carry a definite long-term risk of cardiac events like stenosis, thrombosis, or even myocardial infarction later in life.
What about mortality?
Thankfully, death from Kawasaki disease is rare in countries with good access to treatment. Mortality rates are quoted quite widely, maybe 0.08% up to 3.7% in some older studies or different settings. But in the UK, for instance, there were actually no reported deaths directly attributed to acute Kawasaki disease between 2013 and 2015.
That's very positive.
It reflects how effective IV treatment is. But because we don't fully understand all the potential very long-term effects on blood vessel health, long-term follow-up, especially for those who had aneurysms, is often recommended.
Right. And just to be clear for listeners, it's not contagious, is it?
Absolutely not. Kawasaki disease cannot be passed from one child to another. It's thought to be an individual's immune response to a trigger, not an ongoing infection itself.
Okay. And finally, what other complications can arise besides the really significant heart issues?
Well, the coronary artery abnormalities are definitely the most serious potential complication, leading to risks of MI or other cardiovascular issues down the line.
Hmm.
During the acute illness, some children can develop a temporary, usually self-limiting arthritis. You can get inflammation of other blood vessels elsewhere in the body, too.
Any other rarer things?
More rarely, you could see inflammation of the sac around the heart pericarditis or the heart muscle itself, myocarditis. Problems with heart valves, arrhythmias, or even heart failure can occur in severe acute cases. Dehydration can also be an issue just from the high fever and poor feeding.
And does it come back? Can kids get it again?
Recurrence is possible, but it's very uncommon. The risk is estimated at less than 1%.
Yeah.
So thankfully, most children who have it once won't get it again.
Well, this has been an incredibly thorough deep dive into Kawasaki disease. I think
Yeah.
exactly what our listeners need for their MSRA revision.
Oh,
The key takeaway really seems to be, it's a serious condition, yes, but it is treatable. And that prompt recognition and treatment are absolutely crucial to prevent those potentially lifelong heart complications.
that's the bottom line. Remember those clinical features, FRA-SHBI is your friend, and understand the importance of early IVI and aspirin. Definitely revisit these points as you revise.
Absolutely. And for even more fantastic resources to help you really nail your MSRA, make sure you check out pastthemsra.com.
And freemsra.com too, lots of great free content there as well.
Both brilliant resources.
Ultimately, having a solid grasp of Kawasaki disease is just vital in pediatric practice. Being able to spot those signs early, well, it can genuinely change the long-term outlook for these young patients.